Talking and presenting, and then why don't we have, screen just left. Alex, you wanna do this one?
Yeah.
Okay, that's what we got, Kim and Alex. All right, and so give Kim you want the forwarder, we'll give Alex the pointer?
Sure.
So you can forward with this, little arrows on the keyboard.
Okay. So we have a 72-year-old female, there's a nasal shadow in her visual field since cataract surgery in 2021. Medical history, she is a vasculopathy, also has fibromyalgia. Surgical history, has a heart history, hysterectomy of vein strip. In terms of systemic meds, lisinopril, ibuprofen, aspirin, codeine, Bopill. Ocular history, she is pseudophakic, and then BA is 20/20 in both eyes, and IOP is normal.
So you guys are younger than me, is fibromyalgia a real thing, or is that still not a real
Still
thing?
kind of not a real
They have a
thing.
long list of medical issues.
A lot of people say it doesn't exist.
A lot of times I have like 20
That's what I always
allergies.
thought, I always thought it was one of those things that.
They
didn't
stressed
exist.
in med school though, for us that it was like a real thing
Did they? Okay.
in our med school.
Yeah.
You better treat it with something.
Yeah, they're like, you guys have to
Take
make
it
sure, take it
seriously.
seriously, like there's been
You
studies.
can't tell them
show
they're
that
crazy,
it's been
obviously.
No,
linked
yeah,
to
that
like
never
stuff
ends well.
wrong, Weird stuff.
But for me, it's a red flag, like when they
Right.
come in with some visual complaint that seems like it needs to go to Dr. Drucker, maybe something neuro-ish. Seeing some visual disturbance and I see fibromyalgia and 40 allergies, it's just a wacky patient, so.
Yep.
Okay.
I'll deal with this wacky.
Sorry to divert you, but.
Allergy to Benadryl.
All right, go ahead, Richard.
Tongue pill, I like that too.
That's good.
All right, Kim, why don't you keep moving?
Oh, yes. Okay, there is a bit of artifact in.
Okay.
On this photo.
We've got a color from this photo of the right eye. The nerve looks pinkish. It's hard to tell the cup to disc ratio of it. It's flat. You see well-defined borders. The macula, looks more or less okay. There's maybe like a little bit of like kind of scattered hypopigmentation. My attention is drawn to the vessels. They look a little kind of abnormal, like maybe they're changing in caliber. It looks pretty normal, actually.
Yeah, it's mainly that area, just temporal to the fovea, and I think the rest is all artifact.
That,
Yeah, a little hypopigmentation.
are the borders sharp or blurry, or
Some of them are sharp, some of them are blurry.
and how big is it? About.
About I don't know, 60-70% of the disc.
And then, is there anything else around it? Trying to probably should have these things like company they keep. Do you see anything else wrong?
Superiorly, there's a couple little dizzles, a couple little hypopigmented spots. I'm looking at the vessels kind of going towards it, they look pretty normal.
Okay.
I'm not too concerned. I would see this eye and not think twice.
She's
Agreed.
20/20.
Agreed.
Okay, so left, I think there's just way more artifact on this side, so.
Okay, kind of the same deal. Color
These
from the
little
photo.
things may be epiretinal membranes. You see these, sometimes these weird segmental, sometimes you see these little patchy shimmery, and when you go on the OCT, there's like a little membrane.
Just kind of like looks like kind of a deep cup now. I can see like a little bit of the cribriform there, but I mean, this looks pretty normal to me as well. I like to see the OCT.
That is coming up, but first we have, this is same as last. And then here.
Okay, so this is an infrared,
No.
Back.
a fundus blue light autofluorescence, a BAF. The nerve is dark
Yeah, the vessels are black.
and the vessels is black. So everything looks normal, but my attention is drawn to that previously hypopigmented area on the color fundus photo. And then here you see kind of a mixed pattern where there's some hypo autofluorescent and some mildly hyper autofluorescent areas. So kind of speckled in that same kind of area there.
It's interesting, and those dark spots are really probably dead spots. Those little, because what's your complaint again?
The nasal shadow.
Yeah, it's just, you see the shadow nasally in that eye where that spot.
And then she's got something in her temporal macula. Okay. This looks fine to me. It's normal.
Just some more, oh,
That's
sorry,
the-
this is the eye.
This is the infrared. So again, on the infrared, we see some hyper reflective spots in that same area.
Yeah.
So there's something going on there, maybe.
So
It's
right now
normal.
it's this. Here's that OCT or
At the right eye here, we're looking at that spot that was temporal to the macula, and what we can see is the retina does look a little bit ratty. There's some, it looks like disruptions of the outer layers of the retina. There's a little bit of hypertransmission, so it does look like there's a little bit of atrophy there of some of the outer layers.
Yeah, exactly. So there's that hyper-reflective kind of foci, some loss of the ISOS, and then the outer retina is looking a little bit less.
And I'm trying to see if like the choroid is thicker than it's supposed to be. It doesn't look bad. It looks about fine. The quality's not very good, but this looks normal, and those same areas of disruption and outer segments are not present here.
Exactly. And then we have just kind of different cuts, so. we can
Different
just kinda
cuts.
Go through them.
So let's go over one of those
We'll go over this one.
hyper reflective areas. I wanna see what that looks like. Go up, oh, right there, okay. Yes, I mean, there's some loss of the outer retinal layers there.
And I like that you picked up, one of you said the hypertransmission, you said that.
Yeah.
Because that seems to be one of the most reproducible,
Giant
that's what we use more and more, that seems to be something everybody can agree on.
Yeah,
You know, you're having trouble like this layer, that layer.
and then this one too, you can see the other retinal layers, they just kind of are collapsing downwards. So like, it's like a sinkhole of the retina. All right, keep going. Yeah. All right, so the question is, what caused it?
Yes, so summary of just kind of her symptoms, so that nasal shadow, and then everything in terms of imaging showed in the temporal area, just temporal to the fovea, hyperpigmented areas, and then on FAF, autofluorescence, hyperreflective areas on the IR and OCT, and then disruption of the RP, ISOS, and then a little bit of the outer retinal areas otherwise. Okay, differential.
So the differential is pretty broad. It looks unilateral in this patient. She was what? She's older, right? She's like 70, 60 something. So I mean, anything that can cause loss of the outer retinal layers or outer retinal layer atrophy, I don't know, macular degeneration.
That was, she came in with the diagnosis of macular degeneration.
Oh, okay. Well, maybe it was like an old central serous that resolved and she had some atrophy from it. Macular degeneration, drug-related toxicity, maybe,
Like, what's the big one?
plaquenil, tamoxifen. So I don't know, I'd say like either some kind of toxic, metabolic, or vascular phenomenon.
Nice.
What about the
So
cataract? It came on right after cataract surgery.
Okay.
She's very clear on that. She's like,
So.
my vision was fine, I had cataract surgery. and now I have
Well,
this spot next to my
hopefully
vision.
they would have done an OCT prior to cataract surgery. If you could obtain such information, you would show that there were some changes that were already there.
I haven't asked for that.
If this patient came into me and they didn't have those findings, I might try to blame some kind of like a negative dysphotopsia, which would have been in my differential right when she walked in the door.
Mhm.
But it is unilateral.
And you went
and there are
to,
changes.
dysphotopsies don't have OCT findings,
They do not.
so.
They do not. So if the OCT was normal, that's what I would be blaming, and I'd probably.
And they tend to have a temporal shadow. The dysphotopsies are usually.
It's like that, yeah, exactly. It's like a rim defect, yeah. So
Okay.
what was it?
So I have my full differential here. So I specifically talked about different kind of photoreceptor loss
Oh, wow.
causes. So you have your vitreomacular interface disorders, your retinal dystrophies, and then other. So this includes like AMD, drug-induced or plaquenil, like you mentioned, trauma-induced, photo-induced, and then this other entity. I had never heard of acute retinal pigmenopathy.
Acute retinal pigmenopathy.
And
I
so,
think you can get that like after a viral illness or something, it's just like.
Yeah, that's like
You have like,
Wills disease, but I think it's been renamed.
you have like ratty layers and they just
Yeah.
kind of resolve after time.
Yeah, but I think that's now folded into acute macular. I think that's an old diagnosis, but anyway, go ahead.
okay, so essentially because it happened directly after cataract surgery, that has a role here.
You would blame the
So-
cataract surgeon for that?
Yeah.
God.
if you're running.
I don't think I actually honestly.
Of different ways that light can damage the retina, there are three main ones that BCSC talks about. So there's mechanical damage. So the light produces these gas bubbles, shock waves, and an example of this is a YAG capsulotomy. For thermal damage, you have the light that basically causes an increase in temperature, and this causes damage to the tissues. That's like their laser photocoagulation. And then in our case, we're presuming it was this photochemical damage. And so this is via production of like ROS, reactive oxygen.
So maybe it was a
species.
resident case, they need the Rexus tube.
This was actually a good surgeon. This was a,
It was, and they just tried to reposition it
I don't
for
know,
an hour.
yeah, I don't know what they were doing, but 99% sure this is right.
Yeah. So classically, you think of like solar retinopathy as the main kind of example of this, but they actually did specifically mention overexposure from operating room microscopes. And,
But doesn't that usually go?
Oh, is anybody going to see the
central
eclipse? I'm
macular?
going to see the eclipse.
oh, no,
In
I'm
April.
not.
I'm so excited.
Where
We're
is it?
flying to Cleveland.
Oh,
Next month, there's a solar eclipse.
That's why you're flying up there?
Yeah.
Wow,
That's awesome.
I've been dying to see an eclipse.
It's very cool. I saw it a couple of years ago.
Yeah, I missed that. I was so mad. I missed that one. I'm just mad. So, yeah,
So where are you flying to
I'm
see?
flying to Cleveland.
Oh,
Yeah, my
okay.
brother's in Cleveland.
Uh-huh.
Cool.
Okay. Just wear your sunglasses.
Yeah, I have the eclipse class.
In the middle of the country.
Anyway, go ahead.
That's
Yeah,
that
I think
picture
I
of, like,
watched
Donald
eclipse in-
Trump.
in like
That's a
school and you
subject.
had to wear those glasses.
Yeah.
Remember that.
Um,
Anywho, so in terms of risk factors, there are some listed here from the book, younger age, clear lens, and then if you're taking any photosensitizing medication, so the classic ones are tetracycline and then Soralen, which I think is used for like certain skin disorders, vitiligo and so forth. Protective factors, I didn't really understand the mechanism for this one, but if you have a high refractive error,
It's interesting. I don't know that that would count during surgery because you would correct it. The refractive error would protect you because you're out of focus.
I think this is more for like solar,
Yeah, but for
just like
solar.
straight solar.
Yeah, I
Or
guess
if
if
the
you don't have
retina's
your
like further
glasses.
back.
myopic, but then why hyperopic?
Yeah.
Well, the high
They're
refractive
not good.
error, a lot of those patients are wearing glasses with
Oh,
like
that's true.
high index of refraction and they have thicker
This
glasses.
in your
Yeah,
PowerPoint.
okay.
I could have. Kevin said I should have included this photo in my PowerPoint.
When Donald Trump, like.
Oh, yeah.
At the eclipse, without the glasses.
They told them not to.
Okay, and then, other protective factors, if you have a cataract, there's, less, lights going towards the back of your eye, and then dark fundus pigmentation.
Yes.
More classically, you hear about it in regard to solar retinopathy, so same type of cheek complaint with this kind of mild decrease in vision, and then you could also have that scotoma, central, paracentral. In terms of exam, it looks a little bit different, so here you see that hypopigmented lesion right in the fovea, and then it is surrounded by a bit of pigment in the ring shape pattern. And then imaging is a little bit different here too. You see still like the outer retinal layers, ISOS affected, but you see this kind of almost a column of hyperreflective material. But prognosis, it does spontaneously recover, but it could be incomplete. So you can still have symptoms.
So I think what happened with this patient is they probably had a cataract that was non-trivial. They had blamed their vision loss on the cataract, and just like sometimes you put in a clear lens, you like unveil an ERM, and now they're complaining of, because now they can see well enough to notice there's something going on. They can't blame the cataract, so she probably had this.
I don't think, do you have
Going
more?
into-
Do you have more of it? Do you have more?
I have just some questions to.
Well, so the thing about this case, because I remember these cases from a long time ago, is the microscope toxicity tends to be a spot about that size off center. So your microscope lights are purposely aligned to not hit the fovea because because of this. So they tend to be aligned a little bit off. I remember generally you would see the phototoxicity microscope a little bit above the fovea. But now I think because people operate temporally, it's gonna be to the left or the right. It just depends on which side of that light's on. So this is actually, from my experience, if you look, I didn't look, but from my memory, if you look at pictures of microscope light toxicity, they look about like this. They're about that size, about a disc or two diameters in size, slightly off center. So I think this was right after cataract surgery. And she wasn't on any of the meds, I don't think. She wasn't on any phototoxicity.
The only way you know for sure is if you had a pre-op OCT.
Yeah, which I could ask.
It's not
I
there.
probably should call it. I could check that. But I don't wanna raise suspicion.
Okay, so since we have OCAPs coming up in a week, we have some questions here.
Gosh.
Who
Oh, good
wants
luck
to
with
take
that.
over this question?
I'm going that way.
A 20-year-old man presents with 2 days of decreased vision in both eyes. Oh, that should say after watching a solar eclipse. On exam, visual acuity is 20/60 in the right, 20/40 in the left. Both eyes show a yellow-white spot in the fovea. What characteristic finding on OCT will develop in the next several weeks?
C.
Correct.
Hey, Nabil, you wanna do the next one? We hardly ever get you here. If you're actually
He
here.
might be the or something.
You think you're in the
Yeah, I
R?
think he's.
I'm here. I'm
Okay.
listening, but
Nice
I'm
to
about
see
to
you.
call in. I got my patients.
Oh, okay, all right.
I'm about to call them back, but,
All right.
yeah,
No, we
otherwise.
could have Madeline do it. We gotta call on Madeline. All right, Madeline, you do the next one.
This question?
Yeah, sure, why not?
Okay, a mother brings her 12-year-old son who complains of acutely blurred central vision OU for the past 24 hours, accompanied by temporal headache. Best corrected visual acuity is 20/40 in each eye. Child notes missing lines on the Amsler grid. DFE is as shown in the image.
Oh, I
With
didn't show it.
findings in the left eye.
You know what,
Which
make
of
it
the
easy.
following could increase the child's presumptive diagnosis? Is this the Sorlene, the one you were just talking about?
Yes,
The
exactly.
photosensitizing? Okay.
So Sorlin, and then the other one was tetracycline, which, you know, is the photosensitizing.
And what is Sorlin?
It's used for skin disorders like vitiligo
I think
and
it's
something
used
else.
for psoriasis. That's like the
True,
PUVA,
Sorlin.
right? The Sorlin and UV light exposure therapy. Look up PUVA, PUVA.
I just Googled it. It says, yeah, psoriasis, vitiligo, and cutaneous T-cell lymphoma. It is a photosensitizing drug to
Yeah.
help with exposure to UV light like they use for psoriasis.
And it can cause vision loss though in the absence, just a regular person?
I
Maybe
think
there's
it's photosensitizing, so it increases the phototoxicity associated with like viewing the sun and such.
I actually had a patient.
Okay.
Stare at the sun.
Photosensitizing.
I really, I did the ER,
Yeah,
yeah. And I was like, it's gotta be solar and opposite.
Yeah.
She had a scotoma.
I actually had two. One was like welding and then one was staring at the sun.
Oh, and Sorlin?
No, not medication, but just
Okay,
in
here's the
the
next one.
ED.
And their chief complaint was.
Did you have
That's
a-
it.
Scotoma.
Okay,
Mhm.
thank you, very good.
Question.
Yeah.
Indirects. How long until there's damage?
I think the patient will be punching you first. I think they have to be under anesthesia. I think they'd be kicking and screaming. The only thing I've heard about damage, I remember Sam Jacobson. And I follow this true, for patients with retinal dystrophies would minimize imaging. So I don't get, this is why I do this for conference. So I'll sometimes get pictures, I'll get a nice Claris, or now we have the Optos, maybe an autofluorescence once to bring in, but I don't get autofluorescence ever again in a patient with a dystrophy. Because I think their retinas are, because if you ever had an autofluorescence or the Claris or the Optos, they're pretty brutal pictures. And so, so I try